I'm going to hand it over to Dr. Lim for the first senior lecture of today.
Alrighty, good morning, guys. My name is Chris. It's going to be my senior lecture.
Got it.
Alrighty, so again, welcome to my senior lecture. So for my senior lecture, I'm going to be talking about 5 relatively interesting cases I've had over the past 2 years. These are all cases I've seen. These are all cases at County. I do want to make this a little bit interactive, so I'll be asking you guys for questions. You can also write in the chat if you want to participate. Why did I choose this for my senior lecture? Nothing really special, really simple. I like seeing patients. I think we all, to a certain extent, enjoy seeing patients, at least interesting patients. I think that's how we really grow as clinicians, is seeing a lot of patients. As they say, more patients, more learning. So here are 5 more patients to learn from. We have your case. We have an alcoholic case. We have a headache case. We have a SAG case. We have a EPG. All right, so our first case, we have a 41-year-old female. She's got an issue of bilateral tympanostomies from a worsening left ear pain for the past 2 weeks. She's got some pus coming out the left ear, also endorsing some associated vertigo, dizziness, double vision when she looks to the left. Otherwise, no fevers, chills, cough, rhinorrhea, headache, numbness, weakness, the nausea, vomiting. Otherwise, really nothing else. Examination-wise, vitals are normal. She looks a little bit uncomfortable due to pain. She's got some tenderness of her left ear, specifically the left tragus. She's got some tenderness of the left mastoid. And then internally, the auditory canal looks relatively unremarkable, but the TM is erythematous. On your nerve exam, you note that, interestingly, she has a left cranial nerve 6 palsy, which, if you ask the patient to look to the left, it would appear something like this. And this is Roosh on his neural rotation. So, any ideas or suggestions of what you would do next? Would you get labs? What kind of imaging? Any consults? Anything you'd be particularly concerned about? Type in the chat or.
Yeah, I'd get labs.
Right, so
I'd get imaging.
Labs, labs.
Get a CAT scan.
CAT scan, all right.
MRV.
MRV, nice.
David Warshaw said mastoiditis, intracranial abscess.
Nice. So definitely had CT.
Cavernous sinus thrombosis. Flores. Shar said get all the
So you're Angela, so you're a good doctor. So you get labs, you had CT non-con, you got a CT temporal. We decided to do IV unison. Empirically, we rated Adidon-Zosyn, I think we're pseudomonal coverage, and then we got an ENT consult. I think it's reasonable in hindsight to get a neuro consult, but we felt more strongly that this was probably more ENT related, so that's what we went with. I'll tell you that the labs are all completely normal. Imaging wise, the head CT is normal. However, your temporal bone CT shows complete opacification of the left mastoid air cells, opacifications of the left middle ear, complete opacifications of the left petrous apex, and this may suggest what's called Petrosciphositis. What's that? You guys remember, everybody here knows you have your temporal bone, and then a portion of your temporal bone is the petrous portion. And then a portion of your petrous is called the petrous apex. All right, so inflammation, infection of this small portion called the petrous apex is Petrosciphositis. Very simply put, basically the first sign is saying this patient has otitis media and mastoiditis. Not surprising. I take this last line to basically say that they have some inflammatory, probably infectious process of the osteomyelitis of the petrous apex. Putting this all together, There's a syndrome called Bragg-Nigo syndrome. It's basically a triad of otitis media, mastoiditis, and cranial nerve 6 palsy. Typically occurs when you have otitis media that goes untreated and it progresses, spreads to adjacent structures, to clinical diagnosis supported by imaging findings. You treat it with IV antibiotics. For this patient, she got admitted to ENT. She got an MRI that basically confirms all of this. Not sure why, but hospital day 13, she got what's called a mastoidectomy with transtemporal approach. And ultimately, she went home with a PICC line, IV antibiotics, cephalpine, and flagyl. So that's our first patient. All right. We've all seen this next patient, alcoholic. She's in CCT to on the right. 52-year-old female, alcohol abuse and depression. It's a notification for being found down. Very poor historian, but from your collateral information, seems like she fell multiple times today in the setting of drinking a lot. She does say that she's more depressed and she's been drinking more than usual. Usually she drinks maybe 1 liter of vodka per day, but since yesterday she's been drinking 3 bottles of liquor. Right, she's a little tachycardic. Her ABCs are intact. She's a little confused. Neuro exam is fully intact. No obvious deficits. However, she does have a lot of signs of trauma. She's got occipital hematoma, forehead ecchymosis. She's got ecchymosis up and down her extremities. Her belly is diffusely tender, but it's not peritoneal. It's nice and soft. It's not rigid. Her back is clear, and her VAS is negative. All right. All right. So for this patient, I feel like there could be 2 ways of approaching this. I think everybody would get trauma labs imaging-wise. I think most people would probably PET scan her. So trauma labs, PAN scan, trauma consult, and EKG. In hindsight, I think it's also reasonable to activate a level 2 for this patient. Potentially, I think maybe some people would do that given the kind of unreliable patient, lots of signs of trauma, unclear story. I think in our case, though, we got a just regular quote-unquote level 3 trauma consult, but guess it didn't really matter because we PAN scanned her. Her scans were surprisingly completely normal. Right? Trauma signed off after the normal imaging. Her EKG was sinus tag at 108. She got thiamine, folate, some fluids, some pain control, and she started to get a little bit tremulous, and she's still tachycardic, so we gave her a little bit of Librium. All right, so here's her labs. Her bicarb is 13. She's got that 2-to-1 AST/ALT, high gap, CK 2000, lipase 2600, alcohol 230, acidotic, bicarb low, lactate super high, not pregnant, UAE tox negative. So my interpretation of this, she has, of course, alcoholic hepatitis, rhabdo, pancreatitis. She's got this high gap metabolic acidosis. All right, so we do our best to resuscitate this patient. After we gave 3 liters of MS, her bicarb is a little bit lower, about the same. Her gap is a little bit lower, about the same. At least her pH, improved. But her lactate was downtrending, but not quite as much as I would have expected. I felt like after 3 liters, we would have cleared more lactate. She would have improved more than just 9.2 to 7.6. So in summary, again, 52-year-old female, chronic alcoholism, multiple falls in the setting of binging alcohol. Her Trauma evaluation is basically unremarkable. She's got rhabdoid pancreatitis, A9 got metabolic acidosis. Are we missing anything? What do you guys think? Tox, someone said.
Yeah, what's the osmolar level?
Osmo gap, or osmo level. Okay.
Yeah.
Beta hydroxy, yes.
Yeah.
So the osms was very high. I think it was like 366 or something. I don't have it here.
What was the
230. Yeah, which is in a way reassuring. Anyway, so in hindsight, we realized something else on our differential we were maybe missing. We did some add-ons, back cost of beta hydroxy was elevated. We consulted MICU for AKA. They said no, but she got admitted to medicine. So for anyone who's a chronic alcoholic who comes in with a recent binging episode, you should consider AKA. The tricky part, the hard part is that oftentimes they present very similar to your typical just regular intox or even withdrawal, abdominal pain, nausea, vomiting, dehydration, tachycardia. But in these AKA patients, overall they seem sicker. Your gut might tell you that something else might be going on. And if you do get labs, oftentimes they have a lot of lab derangements. So treatment-wise, D5NS, electrolyte repletion, supportive care. In terms of tox, I think the main thing to cure is toxic alcohols, which specifically ethylene glycol can give you a very, very high lactate and a high osm. However, I believe that if you have a alcohol level that's pretty high, like just regular ethanol, then in a way that's protective of the patient. Just by the pathophys, the alcohol dehydrogenase enzyme has a higher affinity for ethanol. And actually the treatment for, at least once upon a time, treatment for methanol and ethylene glycol was ethanol. I think, Silverberg, did you have a question or comment?
What was the calcium on this patient?
I don't remember exactly, but not too crazy, not remarkable. Why do you ask?
People with ethylene glycol injection usually have a very low calcium
Okay.
because they're making calcium oxalate crystals.
Right. Dr. Sinner?
Two things. Lactic acidosis can never be attributed to alcohol.
Mm-hmm.
A great study by Sinders and Pathology 3 years ago looked at the correlation between alcohol levels in the trauma patients who had no injury and lactate. There's no correlation. In fact, there's no pathophysiology that alcohol would cause increased lactate. Also, in alcoholic ketoacidosis, the phosphate levels are usually very, very low.
Mm-hmm.
And it's one way to separate out alcohol from diabetic ketoacidosis. Is in diabetic ketoacidosis, the phosphate levels are in the normal range, or maybe a little low, but because of starvation in the alcoholic ketoacidosis, the phosphate levels are extremely low.
Thank you. All right, third case.
Can I?
We got a question on the bench.
Oh, okay, sorry.
Yeah, we have.
It's okay, like the drug center always said that you have a suspicion of like alcohol, just give the result. There's almost no side effects, so
Yeah.
I just say.
It's expensive, but otherwise very effective, yeah.
The open renal failure.
The alcohol level is 11.8.
It's okay.
It's up your ass. Yeah.
Okay, wait, do we have a question?
We're wondering about the natural course of the pathology. Is it something that would naturally resolve versus something that could be?
I think if the patient stayed home and nothing was done, this could be a life-threatening condition and you could potentially die from it. And otherwise, I mean, I'm not exactly sure. I think if it's severe enough and you're acidotic enough and your ketones are very, very high, those things can lead to other complications like make you pass away. But if it's kind of mild, and probably, even if nothing was done, eventually it would self-resolve. So answer your question.
Alcohol ketoacidosis almost never needs to go to the ICU. They resolve very quickly with calories.
Okay.
You just give them, D5. They can do, that's what they need. And that will resolve very quickly.
Okay.
And you almost, no matter what their pH is, they almost never go to the ICU. They don't need insulin drugs. They don't need.
Nice.
I mean, they need that D5. If
Mhm.
they don't get that D5, they get worse. The other thing here, though, is she also has pancreatitis. And pancreatitis has a lot of complications that you can die from. And so you have to worry, obviously, that this lady's at risk.
Yeah.
As far as saying she has rhabdo, usually rhabdo, the CK is higher than that, but what you want to do is you want to hydrate them and repeat the CK.
Mhm.
See if it's going up. But with rhabdo, it will. And then it may go 2,000, 5,000, 10,000. I've seen that happen several times. So you want to do that. And then again, rhabdo, if it gets bad, real rhabdo, that's life-threatening. You can get hyperkalemia with it and other electrolyte stuff.
Okay, go ahead.
Oops. All right, third case, 43-year-old male, history of hypertension. He's got baseline right eye blindness, secondary to some trauma a long time ago when he was young. He's coming in with this really, really bad headache, worst headache of his life. It's everywhere, constant. Woke him up from sleep at 1 a.m., maximum onset thunderclap about 8 hours ago. He's got some photophobia, phonophobia, otherwise nothing else. It's probably the most dramatic presentation of a headache I've ever seen. Saw this guy in the room, like 6th right. He was on the floor, crawling, kneeling, just like clenching his head. So he was severe distress. Otherwise, from what I could gather, his examination, including neurologically, was unremarkable. He got some morphine, and he got a non-contact CT and a CTA. At the time, my rationale for the CTA was to check for any aneurysm. All right. Please work.
Try to.
It's not what you think, but there is something. You guys always look at the sagittal, right?
Yes.
I also
Yes, great. So if you picked it up, good for you.
Are the ventricles tight?
A little bit. But he's got a really large pituitary adenoma. So, large pituitary adenoma. We also got an MRI in the ER that showed small internal foci of hemorrhage within the adenoma. Basically, a pituitary macroadenoma with pituitary apoplexy. We spoke to neurosurgery, endocrine ophthalmology, was admitted to neurosurgery, and very aggressively got a craniotomy with resection, and then he went home.
Chris, what?
Yeah.
So did he have hormonal stuff? Did he get
So-
hypotensive and have evidence of hypoadrenalism?
His vitals were all normal. They did send off like FSH, LH, growth hormone, all that stuff. I don't remember the specifics, but some of them were very low. I think his TSH was very low. His testosterone was very low at 25. Some of the others were completely normal. So it was a bit of a variation. His prolactin was also normal. All right. A sad case. 24-year-old female, no medical problems, coming in with weight loss, anorexia for 6 months. It's coming with her mother who says she's been losing weight on and off for some months. However, for the past 1 week, she's been losing significantly more weight, about 20 pounds in 1 week. No appetite, not eating, drinking, very lethargic. Also more recently, in 1 to 2 days, chest pain, shortness of breath, and palpitations. And they came from Guyana about 3 years ago. She grew up there. Initially, I had this maybe question of intentional weight loss, but she did not, 100%. So basically, this is kind of what she looked like. She was hypotensive, tachycardic, hypoxic, incredibly cachectic, especially for a 24-year-old. We basically calculated her BMI and it was 11.
Oh, see.
So before the labs even came back, actually this patient was also in CCT2, right? The portable X-ray comes in, and we get this X-ray. What would you guys be concerned about? TB? Yeah, miliary TB. We were also considering like HIV, PCP, fungal, COVID. Nothing about how thin she is. Alright. So we spoke to ID and NICU. NICU took her. ID said start right away. Her cultures all grew AFB, but after 1 to 2 days on red, she did expire. All right, last case. Also a CCT, 58-year-old female, no medical problems, coming in with chest pain. It's going to be a clearance due to bradycardia. And these are her vital signs. As the typical process of CCT, you get your EKG. You guys have a minute to.
What was that?
I can say a type 2-1.
All right. 58-year-old female, no medical problems, chest pain, shortness of breath, 3 days, mid-sternal, intermittent, a little bit exertional, sometimes a little bit diaphoretic, otherwise nothing else, no PE risk factors. Let's see, her examination, completely normal, except bradycardia, very well appearing, sitting comfortably, normal mental status, no distress. Her labs are all completely normal. Troponin, DNP, TFTs, electrolytes, X-ray is normal. Let's say her bedside sign was also unremarkable. So you have no other information other than this EKG to make your diagnosis. I don't know if the chat heard the attendants say some suggestions, but
Yeah.
priorities.
Don't ignore them. Just keep going.
All right, so let's start easy. I think everybody agrees. These are all keywords, right? It's followed by QRSs. And I question you, is that a keyword? If this looks similar in morphology to that, and this looks kind of similar to that, that looks similar to that, those are keyways, and those are all keyways. Then the next question is, where are the T-waves? They should be in between, right? You can kind of see a very subtle upward deflections in between, which makes you wonder, are those the T-waves? You can look in waves B2 and 3, and it's a little bit more prominent, I guess, more noticeable, this upward deflection. So P, QRS, T, P, and drop. Same thing here. So if this is your T, then yes, indeed, these are your T's. So it was already mentioned, but had a Movid spec 2, spoke to cardiology, mid to med tele, David Warshall, Alheim, got a pacemaker and went home. That's all I have. Thank you, guys.
Great.
Any questions?
Young woman died, did she also turn out positive for HIV?
No, it was negative.